All right. Good morning, everyone. Thank you so much for having me this morning. It's great to get to present at Echo Rounds this week. So, as Dr. Chow said, my name is Jeffrey Lam. I'm a PGY5 in cardiology from Queens. The topic I picked for today is one that has come up time and time again throughout my time as I'm learning how to read echoes, and that is how to quantify the left heart chamber, specifically the left ventricle and left atrium. For many of you, this will be a review, but nonetheless an important refresher on a fundamental topic of echo interpretation and image acquisition. So I have no disclosures, although I will acknowledge that I am still learning a lot of this myself as well. So if anyone has any comments at any point or wants to add anything, feel free to hop in at any time. So the objectives for today's talk is we're going to provide a brief glimpse on the past, present, and the future of chamber quantification. And we're going to review the current guidelines on quantification of the left heart chambers, left ventricle and left atrium. And then we're also going to talk a bit about the limitations of various techniques and discuss ways that we can try to overcome them. These are some of the key guidelines that we'll be referencing today, and this talk will heavily reference the 2015 ASC EACVI guidelines on chamber quantification. So if you're like me, when you were first learning all of this, you're wondering, why is this important? Why do I need to know this? And so it's important for a few different reasons. First and foremost, the accuracy of the measurements that we get ultimately form our interpretation of the echo itself, and those can ultimately affect the patient's management depending on what we end up reporting on the echo. The other thing that's important as well is that it helps us maintain consistency within ourselves, but also between other people, between different labs, and trying to be consistent with our reporting and our measurements. So as we're all familiar with, there's the 2015 Echo Chamber Quantification Guidelines, and before that was 2005's iteration of the guidelines. But what did we have before 2005? And so before 2005, there wasn't any actual standardized guidelines published. And so oftentimes it would look more like this. So this was Wayman's Principles and Practice of Echocardiography, which was a popular book at St. Michael's Hospital for referencing the normal values. If you flip to the very, very, very back on page, I think like 1,200 or something, you'll see this, which ultimately lays out a lot of the normal values that they would recommend using. This book itself, specifically the one by Wayman, took data from only 72 patients and compiled those to come up with these normal values. The issue with this was that different readers and different labs would use different resources and different textbooks. And so there was often discrepancies between labs or readers when using different reference values. So this was identified as an issue, and therefore in 2005, the ASC published a guideline that helped outline how chamber quantification should be done, both of the left and the right heart chambers. This one took 510 patients and pooled 510 normal, healthy patients' values together to come up with this guideline. This was then followed in 2010 by this guideline that was chaired by Dr. Rudsky from the Jewish General Hospital. This outlined a lot more information in terms of quantification of the right heart chambers itself. The values that they got were actually different than the ones from the 2005 guidelines. And the reason they thought that was because they pooled more studies and had larger populations of patients. This was subsequently followed up by the current 2015 guidelines that we use in everyday practice, from scanning to echo interpretation. And as I said, this will form the basis of today's talk. So before we can talk about identifying what's abnormal, it's important to reference what is normal. So the 2015 guidelines took 7 different databases of patients and pulled them together to try to come up with these normal reference ranges. It's important to note that these reference ranges were made for TTEs that were done without ultrasound enhancing agents, so non-contrast echoes. They included various aspects of patient demographics, and they were trying to get a population of patients that did not have any known history of cardiovascular disease or any of the other conditions that I've listed on the screen here. Now, the authors had also mentioned that there are a few different values that they have provided expert-based consensus opinions on to provide partitions. And so sometimes when you pull up the guidelines, you'll see things are listed as mildly abnormal, moderately abnormal, or severely abnormal. The authors wanted people to know that this was mostly expert opinion, but the reason that they put forth those things is because they wanted consistency in reporting. And so if one reader reported something as severely abnormal, using those cutoffs, ideally be able to translate that to another reader looking at the same images. All the other parameters were therefore reported as just mean plus standard deviation, and anything that was more than 2 standard deviations from the mean was defined as being abnormal. So this is just an example on the 2015 guidelines on what they meant when they said normal, mildly abnormal, moderately abnormal, severely abnormal. And again, this was mostly based off expert consensus opinion on how they would partition these cutoff values. So then we want to the LV cavity or LV size measurements. This was done mostly on 2 different ways, via linear dimensions as well as through volumetric measurements. And these ideally should be indexed to body surface area, although we recognize that body surface area does have its own limitations as well. Oftentimes when we're making our measurements, we will either take them at end diastole or end systole, and the guidelines have recommended that end diastole be defined as the first frame after mitral valve closure, and end systole to mean the first frame after aortic valve closure. If those aren't visible, you can use different aspects of the cardiac cycle where you find that the chamber is either largest or smallest. So in terms of how to actually, or how we do the linear measurements, we typically take them on the parasternal long axis view, and we want to take the measurements perpendicular to the LV long axis. These measurements should ideally be taken either at the level of the leaflet tips or just immediately below it. And this image here shows a good example of where we should be doing our measurements in an ideal patient. Now, in terms of basal septal thickening, this is an exception to the rule of where we want to measure as close to the mitral valve leaflet tips as possible. We don't want to measure at the level of the basal septal thickening because that might overestimate the thickness of our interventricular septum. And this is a common thing that we see in patients who are, for example, older and tend to have more basal septal thickening. And so this slide shows well that on the right, if we've measured a bit more close towards the apex of the left ventricle, we get a more realistic representation of the actual interventricular septal thickness. Whereas if we're measuring right at the basal septum, it'll be, unfortunately, fairly overestimated. Now, in addition to this, when we're looking at the parasternal long axis trying to make these measurements, we ideally don't want to see the papillary muscles in there either. And the reason for that is if you were to X-plane through that, you would see that, unfortunately, it's oftentimes would end up being off-axis and therefore give us an inaccurate measurement. So on the left side of the screen, you see that the optimal measurement has no papillary muscles on the parasternal long axis. And if you were to X-plane that, you see that it's a fairly good representation of the actual diameter of the LV cavity. Whereas on the right side of the screen, you see that there's papillary muscles visible on the long axis, and X-plane that is unfortunately a bit off axis. Although this is certainly recognizing the fact that that might not always be possible. There are factors outside of the sonographer's control that might impact what type of image that we get. Now, in terms of the linear measurements themselves, the guidelines recommend that these be taken on the 2D parasternal long axis rather than on M mode. And the reason for that is because the M mode beam might be leading to an oblique cut. And so we want something that is perpendicular to the LV long axis rather than an oblique cut that might overestimate our measurements. Moving on to the volumetric measurements, so the actual LV cavity itself and the volume of it, these can be derived in a couple of different ways. The linear measurements are no longer recommended for clinical use, but they include the Teichhold method and the modified Quinones method. What's recommended by the guidelines is to use tracings of the interface between the compacted myocardium and the LV cavity itself. The most commonly used method of doing so, and the one that's recommended by the guidelines, is using the biplane method of disc summation, or the Simpson's method that we call it. And the other way of doing this as well is through the area length method. So in terms of the biplane method of disc summation method, on the right you'll see a good example of these measurements being taken. You want to do the tracing along the border of the compacted myocardium and the LV cavity. We want to remove or not include tracings of the papillary muscles or the trabeculae. When you're making the measurements at the mitral valve level, we're taking it from the point where the leaflet meets the annulus, and you draw a line that connects those 2 points. Halfway between that line, if you draw a line straight up towards the apex, the farthest distance from the annulus, that gives you your left ventricular length. And you'll end up getting 2 lengths, one from the apical 4-chamber view and one from the apical 2-chamber view. The guidelines recommend that we should be using the longer of these 2 measurements in order to use for our calculations. And there should be less than 10% difference between those 2 measurements. If there's more than a 10% difference between your length measurements, then you should look back and see whether or not one of the views is off axis or foreshortened. The computer then takes the tracing that we've done and then divides it up into 20 cylindrical discs and adds up the volume of all of these discs. That then ends up giving us our left ventricular volume. So with this, there's obviously some caveats or disadvantages or limitations to this, one of which is if you can't see the endocardial border very well, it makes it challenging to do this tracing. And the other limitation as well is if the image is foreshortened, that might cause your volume to be underestimated. And so because of that, there is a development of the ultrasound enhancing agents that have significantly helped us with regards to being able to better visualize the LV cavity. The guidelines recommend that these should be considered or used when endocardial delineation is not well seen in 2 or more contiguous segments. So with regards to these ultrasound enhancing agents, they consist of microbubbles that are smaller than the size of a red blood cell. It's a heavy molecular weighted gas, such as sodium hexafluoride, and it's got a shell around it, either phospholipid shell or an albumin shell, depending on the vendor. These microbubbles are very, very compressible, and so when an ultrasound beam hits it, it reflects the beam and shows up as very, very bright on our screens. In terms of any risks associated with these ultrasound enhancing agents, they're fairly well tolerated with less than 1 in 10,000 chance of a severe allergic reaction. And otherwise, in terms of thinking of other potential theoretical risks, in certain vendors where the microbubbles are larger, there's a theoretical risk that if it were to cross from the right to the left side in the setting of, let's say, an interatrial shunt, that might cause occlusion of an arterial, but that is, again, very much just a theoretical risk. So this is an example that well exemplifies the benefit of using these ultrasound enhancing agents. On the left, you see that unfortunately not all of the endocardial borders are well seen, and so after the administration of an ultrasound enhancing agent, the borders are much better seen and therefore much more easy to trace and identify wall motion abnormalities as well as ejection fraction. Now, with the use of the ultrasound enhancing agents, that doesn't fix the other issue, which is that of foreshortening. And so this next image is an example where the ultrasound enhancing agent was used, but unfortunately, you still see that the apex is foreshortened, and therefore, in this case, it would be important to try to re-angle the beam, but also understanding that might not always be possible based on factors outside of the scanner's control. Now, what are some ways that we can try to optimize our use of ultrasound enhancing agents? And so one is through something called flash impulse imaging. So sometimes we'll see in the myocardium, it also appears very, very bright along with the LV cavity itself, which makes it difficult to look at the border. And so when we use flash impulse imaging, the probe will send out several pulses of high mechanical index beams, and that ends up destroying the microbubbles that are within the field. This then makes the myocardium itself look very dark again, and then the LV cavity is then replenished with other microbubbles as it's circulating through the body. This allows us to better optimize the endocardial border in order for us to do our tracings. Now, if there's a high concentration of ultrasound enhancing agent being used, this can unfortunately cause some acoustic shadowing in the LV basal segments. And so, some ways to try to overcome this, one of which is just watching and waiting for a little bit. You can also change the focus down to the LV base to try to help mitigate this. Other ways to try to overcome this is to dilute the ultrasound enhancing agent prior to injection, as well as injecting the solution more slowly. So the reference ranges for contrast 2D echo are unfortunately not well established, and this makes sense because it's more challenging or less feasible to take a healthy population of patients with no known cardiac abnormalities and give them microbubbles or ultrasound enhancing agents for no real reason. But the authors had also posited some potential upper limit cutoffs that I've listed on your screen here. These values are already 2 standard deviations above the mean. And so for values that are larger than these, those would be classified as abnormal. But the authors had also cautioned to the reader that these should be interpreted with caution, and further large scale studies are needed to further, develop this. Beyond contrast echo, we also have 3D echocardiography, of which comes with its own advantages and disadvantages. Some of the advantages of this is that there is no geometrical assumptions. So some of the previous methods had assumed that, for example, in the setting of area length method, the LV cavity is assumed to be a bullet shape. There's no assumptions with that for 3D echo, and it's also unaffected by foreshortening. 3D echo, unfortunately, also has its own disadvantages as well. So this example here, we'll see that, unfortunately, the computer is not tracking very well in terms of trying to map out where to put the borders of the 3D, the LV cavity, sorry. And so this ultimately gives us an inaccurate measurement. A way to potentially mitigate this, if it's done after the fact or picked up after the fact, is that depending on the lab or the computer software that we have, we might be able to do it in post-processing on the computer if the appropriate applications are available. If that's not available, you can go back to the actual machine itself that was done to take the image and find that study, rerun the study, and then see if you can adjust the tracking so that it better models the LV cavity's movement and size and shape. Now, in terms of reference ranges for 3D echo, these were based off of weighted averages of 3 different studies. They've proposed some upper limit cutoffs that are 2 standard deviations above the mean. So just like the last set of reference ranges, these are listed as 2 standard deviations above the mean. And so volumes that are larger than that would be already considered abnormal. But the authors have also cautioned here that further study is needed to delineate reference ranges for a 3D echocardiography. So on this slide here, I've summarized some of the different proposed upper limits of normal cutoffs, both in the setting of non-contrast 2D echo, contrast 2D echo, and 3D echo for both men and women. Now, the thing to note here is that there are significant differences between each of the different categories when compared to their volumes. Anything greater than any of those volumes would have been considered abnormal. So it's important to interpret your studies with caution, and as well as if you're taking a study that was done with 2D echo and then you repeat the study at a future time and use contrast at that time, they might not correlate exactly because of the different cutoffs between the different imaging modalities. Interestingly as well, on contrast 2D echo, they found that the LV cavity itself often ended up measuring larger when compared to non-contrast 2D echo. And so that's something to keep in mind as well when we're making our measurements. Now, moving on to global systolic function, the guidelines recommend using the biplane method of discs to assess systolic function. 3D echo has also been proven to be quite useful in assessment of systolic function, and we use the formula that I've listed on the screen here in order to calculate our ejection fraction of the left ventricle. Moving on to the LV regional function, Dr. Leon Poi actually did a fantastic talk on this exact topic just less than a year ago. And so this next slide won't go into anywhere near as much detail as Dr. Leon Poi did, but essentially the guidelines have recommended using a 16 or 17 segment model to try to display the wall motion abnormalities that we see when we are interpreting an echo. We're assessing the wall thickening as well as the actual motion of the endocardium or myocardial segment itself. And the current guidelines recommend scoring them with the scale that I've listed on the screen there, 1 being normal or hyperkinetic, 2 hypokinetic, 3 akinetic, and 4 dyskinetic. It's important to note as well that the previously mentioned or previously used convention of the number 5 for aneurysmal is no longer recommended in the 2015 guidelines. And instead, an aneurysmal segment should be described separately and further quantified based off of its wall motion. Moving on to LV mass, there's a lot of different methods in order to calculate this, but the one that's most commonly used and the one that's recommended is the linear method, which we use the formula that I've shown on the screen. You'll notice that a lot of the different measurements that we use when we're taking our linear measurements are part of this formula. And so the important thing is that it's cubed, and so therefore any small differences or abnormalities in our measurements will end up causing a significant change in the final number that we get. We also calculate the relative wall thickness, and when we combine the mass and the relative wall thickness together, we get this chart that you see on the right side of your screen that helps us determine whether the patient has left ventricular hypertrophy or concentric remodeling. This formula assumes that the LV cavity itself is ellipsoid, and so you can imagine that any pathologies that cause the LV cavity to not be a perfect ellipsoid will cause some discrepancies in your measurement. And it's also inaccurate in settings where the hypertrophy itself is asymmetric. This just shows that there are differences between the values that we get when we use linear method to assess mass versus the 2D method. But as stated before, the linear method is the one that's most commonly used and the one that's recommended by the guidelines. Moving on to the left atrium now. Quantification of the left atrium follows a few different important things. Ideally, you would get a view that's zoomed into the atria itself to better visualize it. And it's also important to know that the long axis of the left ventricle is not the same as the long axis of the left atrium. And so if you are taking measurements of the left atrium based off of the long axis of the left ventricle, you'll often be foreshortened. And so when you're measuring the left atrium, care should be taken to try to optimize that image, irrespective of what the left ventricle foreshortening looks like. In terms of measuring the actual left atrial chamber quantification, there's a few different methods, the biplane method of discs, as well as the area length method, and the biplane method of disc is the preferred method. The endocardial tracing itself should be done at the end of systole and should not include left atrial appendage or the pulmonary veins where possible. In terms of using the left atrial length, you'll get 2 lengths from the apical 4 chamber view and the apical 2 chamber view. The one to use as recommended by the guidelines is actually the shorter of the 2. This is in comparison to the left ventricle, where you use the longer of the 2, the left atrial length, you use the shorter of the 2. And ideally, your left atrial length should not differ by more than 5 millimeters between the 2 views. Now, moving beyond that 2015 guidelines, a paper that we often use in everyday practice, there were future studies that were published, one of which include the WAYS normal value study, WAYS standing for the World Alliance Societies of Echocardiography. This paper identified that there might have been differences in patient measurements based off of the countries that they are living in, as well as their ethnicities. And so they sought to try to find out if there was any significant differences there. They also identified that the 2015 chamber quantification guidelines was mostly focused on an American and European population, which is certainly not representative of the global population. So the group took data from 2008 different patients across 15 different countries, and they tried to find what might be denoted as normal reference values for LV size and functional parameters. So they didn't look at anything beyond just LV size and functional parameters. They didn't look at the left atrium, or right ventricle. They just focused on the left atrium in this study. And these are some of the key things that they found on that study. For example, they found that there was significant inter-country variability, and they thought that nationality should be considered for defining ranges of normals of the left ventricular volumes. The next slide I have here has a lot on it, but it's just to give you an idea that these authors were trying to find all the different reference ranges for the various countries that they were looking at. And if you look carefully, you'll see that there were significant differences between the various countries. The thing that I wonder when I was looking at this was, when would you consider someone to be part of that country? So say, for example, if I were to move from Canada to any of the other listed countries here, would I still continue to use the Canadian reference values, or would I use the ones from the new country? And if I'm using the Canadian ones, how long will I have to live in that new country before I should be considered, to be using the new or different reference ranges? So that's certainly something to think about as this moves forward. But these have not been incorporated in the current guidelines at this time. So moving beyond the 2019 WAYS study, actually just a week ago, the Journal of the American Society of Echo posted a call for papers, and they had actually indicated that the new issue in early 2026 would be the new issue involving the updated chamber quantification guidelines. And so perhaps in those issues, we'll see more things about different patient ethnicities and updates to different things. But that's just over a year away. We look forward to seeing what we find there. Now, beyond 2026, where do we go from there? And so then we move into discussion about whether or not there's role for other things like artificial intelligence in echocardiography and chamber quantification. In my last, less than 2 weeks in the Echo Lab, I've seen that there's a lot of very exciting things coming to echocardiography and cardiology as a whole that might help us in our workflow, help us in our accuracy of measurements, and that might be including things like ChatGPT or US2 AI in how we practice echocardiography and cardiology as a whole. So to summarize some of the key take-home points that I'm hoping that you get from this talk today, one is that accurate chamber quantification is a very important fundamental aspect of echocardiographic interpretation that involves everyone. So from the moment the patient walks into the room and their positioning to how we take the images and trying to optimize our views, to trying to get images that are on axis, ideally seeing endocardial borders, all the way to in the Echo Lab where we're doing our measurements, checking different reference values. Those all play a very important role in accurate chamber quantification, and ultimately that will affect the patient's management. And so the other thing is to be aware of the different pitfalls and limitations associated with the different techniques that we talked about today, and think about ways that we might try to overcome them. And finally, this talk also hopes to highlight some of the changes and updates that are coming on the horizon in the near future that might help us with improving patient care going forward. And that I want to thank you all for listening. I'm open to any comments or questions that anyone has.